Hi, I'm Dr. Rajesh Chaubal. I'm a consultant at Thane Ultrasound Center and Jaslok Hospital in Mumbai. And today I'm going to be discussing with you elastography. So I'm going to be talking on the techniques of doing liver elastography. And of course, at the end of it, we look at what are the new concepts that have come up whereby we can interpret our studies better. Now, one of the first and the most important thing when we do elastography is that we don't look at it only as images or not only as values. We have to look at the entire clinical picture of the patient. So it's very important that when the patient walks into your clinic, and walks before you do your elastography, you have the entire clinical background in place. So you have to look at the clinical history of the patient. You need to understand what type of disease you're looking at, whether it's a hepatitis B, hepatitis C, whether it's an alcoholic fatty liver disease. You need to look at all the LFTs, any previous scans, if the patient is on medications, and all this has to be kept in mind before you go on to your elastography reading. So before you go on to taking your elastography values, it's very important how we position the patient. So the patient should either be in a supine position or be in this semi-decubitus position, which is what I generally prefer, and the hand should be kept above the head as we have positioned him over here. What this basically helps us in doing is opening up the intercostal space, because this is exactly where you want to scan. You want to be bang within the intercostal space. You do not want your rib shadows to pop into your images, because all that is going to hamper your readings. The other thing you need to keep in mind is normally we do these cases early morning in a fasting status. So 6 hours of fasting is ideally what you should do these studies with. But at times it happens that the patient walks in the afternoon, you have to maybe do the scan at that time. So we have a look at everything, we take all the values. If we think they're getting elevated, this could be a false elevation because of the non-fasting status, and it may be a very good idea to see this patient again the following day. So this is one of the practice that we follow. The other thing is, when the patient walks into the clinic, don't take the patient in immediately. Let the patient rest out for 10-15 minutes, and only after that you can start your scan, because all these things will falsely elevate your values, which you do not want. So when we start scanning, like I mentioned before, we have to go in the intercostal space, because you do not want to scan obliquely. You do not want the rib shadows to come into your B mode image. You have to go in the intercostal space. Remember one thing, the essence of getting a good elastography reading is getting a good B mode image. If you do not have a good B mode image, you will never ever get good elastography values. So that is how basically we position our probe. The other important thing is how we ask the patient to breathe, or rather how we ask the patient to stop breathing. So we do not want the patient to take a deep inspiratory or an expiratory breath hold. We want them to have a mid-inspiratory breath hold. So it's a very good idea that you explain to the patient before you start doing the study as to how you want the patient to breath hold. So this is what we normally explain them. आता मी सांगेन ना तेव्हा श्वास न मध्येच थांबवायचा, घ्यायचा नाही, सोडायचा नाही, ओके, तिकडेच पकडून ठेवायचा. सो आय एम टेलिंग हिम to just hold his breath. When I tell him don't take a deep breath, don't leave out the breath, just hold it there and there. Okay, थांबव श्वास. Very good. Relax. Okay, सोडून द्या. One of the other things we can do is apply a lot of gel. Again, what this will help us in doing is getting a very good B mode image. You have a very good coupling over here and you get a very good B mode image. Starting with our elastography study, now that we have fulfilled all our baseline criteria, we know what we are looking at, we know what the background clinical history of the patient is, we can start with the scan. Now again, before we go on to taking the elastography findings, it's a very good idea that we just scan the patient, we get a general brief idea about what we are looking at. Is there any cirrhosis, if at all? Have a quick look at the portal vein. Go on to the other side, you can have a look at the spleen. You can always check for the presence of any collaterals if necessary, because if you have a frank portal hypertension, we should be able to pick it up very easily with just our B mode findings. Now moving on to taking our elastography reading. Like I said, we have to be within the intercostal space, and one of the common questions which pops up is, where do we take our reading? So as per the SRU guidelines, we can take it anywhere between segment 5, 7 and 8. as long as we don't go in the left lobe of the liver, because what happens over there is we are getting pulsations from the heart, and that is going to hamper our values. And also the other thing you want to do is not go very close to the diaphragm, because again you're going to get reverberation artifacts over here. So anywhere on segment 5, 7 and 8 is absolutely fine. So once we have determined where we are going to scan, what we do is we turn on our elastography mode. One more thing before we start taking our elastography values, we have to do a quick B mode scanning. Just have a look at how the liver is it coarse, is there any nodularity, routine things. Look at the portal the portal vein. Go have a look at the spleen. Are there any collaterals? Is there any ascites? Because this will give you a very good indicator of what we are going to deal with. Now coming on to our B mode, like I mentioned, we need a very good B mode image for which we are scanning within the intercostal space. We do not want this kind of an oblique image to pop up. We do not want these shadows to pop up. We do not want the diaphragm in our picture, or at least wherever we are taking the reading. So we want a very clear image, and ideally we want to avoid even the vessels and the biliary radicals. Now, one of the common questions which comes across is, where do we take the readings, in which segment? So as per the SRU guidelines that we follow, the readings can be taken anywhere between segment 5, 7 or 8. The thing that you really need to avoid is the left lobe of the liver, because this is where the cardiac pulsations are going to pop up, and we do not want this to hamper our reading. So left lobe is a big no-no, but in the right lobe of segment 5, 7 and 8 is absolutely fine. So you do not again want to be too close to the gallbladder, you do not want to be too close to the diaphragm, because this can alter your readings completely. Normally on the machines we have two types of elastography modes. The most common is the point elastography, which over here is called as Elast-PQ. This is what the Philips machines calls it, but of course all the different vendors will have their own different ways and their own different terminology. So in this, if you can see this box over there, what we have is this box which is say roughly around 1 centimeter square in size, and this is the box where we are going to do the readings. So we place this box roughly 2 centimeters below the capsule of the liver. Now the placement of the box is very important. There are a couple of things that we need to keep in mind. The first thing is, before we take the reading, we ask the patient to do a quick breath hold. Okay, Shwas thamba. Sodunde. Okay. So now that I have placed the box over here, there are a couple of things that I'm going to be looking at. Number one, I want the box to be absolutely perpendicular to the wave, to my ultrasound waves. So a very good way of looking at this is we look at these three lines. So the first line is this, which is the skin surface, or where the waves are starting, ultrasound waves are starting. The second is this liver capsule, and the third line that we look at is the top of the box. And we have to ensure that all these three lines are absolutely parallel to each other. So once we are making sure that this is in place, we are quite sure that the box is absolutely perpendicular, and we can go ahead with our reading. And now I have taken the reading. So this is where my box is placed. I have avoided all the major vessels. I have avoided the biliary radicals, which is important because that can alter your reading. And once we place the box, all we have to do is just click the machine which is there on your respective machine, and we button on your respective machine, and we take the values. So normally the value pops up immediately over here on this corner, like we can see over here. This is a value of 1.33, and we go ahead and we are acquiring. So I'm storing this as the first sample. So this is a very easy way, this is a very quick method. So like I said, just a couple of things that you need to keep in mind. Make sure that the box is absolutely perpendicular to the liver surface, and we should be avoiding the vessels, and we should be good to go with these readings. So the SRU guidelines state that we should take 10 samples when we are doing point elastography, and all these 10 samples can be even in the same place, and it doesn't matter. Okay, so you don't need to go in different lobes of the liver, you don't need to go in different segments of the liver. All you have to ensure is that the way you are taking the reading is right, and 10 samples over there should be good enough. Now the other thing that we'll come to is the 2D shear wave, which is recent, not so recent actually, it's been there for quite some time. And this what it helps us in doing is it gives us a better confidence when we take our readings. So this is, most of the newer machines are getting equipped with this, and this is what is going to come up in a very big way. So now you can see that when I have turned on my elastography box, instead of that small box that I had in the point shear wave, I have quite a large box over here. The box can be changed in size. As you can see, I'm making a large box, I'm making a small box over here. So you can vary it from study to study and take your readings. Now what we are seeing over here is this color filling, which you can see. Now I'm not yet asked the patient to breath hold, but you can see that the box is getting filled up with this color. And now if you look at this scale over here, you can see this is very similar to our Doppler scale that we are used to. So we can see that whatever is blue is on the softer side, and whatever is hard or whatever is red is actually on the stiffer side. So you have this scale which goes all the way from 0 to 4.5. So what I do is I'm going back to my elastography, I go back to my box, I make sure the way in which you take the readings is absolutely the same. You have to ensure that the box is absolutely perpendicular to your liver capsule. You don't want it to be too close to the diaphragm. You don't want to place your box in this way. You don't want it to cover, say, the gallbladder. You don't want it to go to close to the heart. So we keep a box over here, and in this case, even if you do not avoid the vessels, is okay, because I will come back to what we have as what we call as a confidence map, which will help us to negate those areas anyway. So it's okay if you include vessels, especially when you have a big box. It's going to be very difficult to avoid the vessels. So again, Shwas Thamba. I'm waiting for a couple of seconds for this box to fill up well. Now you can see that the box is filling up really nicely with color. Shwas Sod. And the other advantage of this technique is I can go back. Okay, so this is not unlike the point shear wave where I have the reading only in one particular segment. I can actually go back and forth on this. I can choose which image or which frame is rather the best, and I can choose where I want to do the reading. So according to me, this is quite a good frame. And now what I do over here is I simultaneously turn on what is called as the confidence map. So confidence map is what is popping up over here on the left hand side of the screen. And again, if you go back to the scale over here, you can see that whatever is red is indicated as 0% and whatever is green is indicated as 100%. What this means is that when you take the measurements, you do not want to take it in this area which is corresponding to red. And if you look at this image on the right hand side of the screen, you can see that this is actually not got filled up with the color. Whereas on the other hand, the area which is blue and which has got filled up with color very nicely, you can see is actually reflecting as green. So even if this vessel pops up over here, like it has come in this particular image, you can see that it's getting reflected as red on this screen. So this, you know that this is an area where you do not want to take your measurement. So once we are done with this, what we do is we go on to a measure, and then you get this small circle, and you can actually change the diameter of the circle. So you can see that I can make it decently large. This is almost 2 centimeters in size, and I can come back to a smaller one. So we prefer to keep it somewhere around this 10 mm mark, which is a good enough size. Now the advantage of doing this 2D shear wave is, number one, like I said, it's a real-time image, so you can scroll back and forth, you can store your loops, you can go back to your loops and do a retrospective measurement also. It's not a problem. And also you can do multiple measurements in a single box. So like for example, in this case, you can see that I have put 2 small circles within this box, and these are actually 2 different measurements. So the advantage is that you can do more number of measurements in a single breath hold. So normally what they say is you can take maybe 2 or maybe at the most 3 readings within a box. Don't go beyond that. But then that means you have to ask the patient to breath hold for a shorter while, and you can take more measurements. So this is especially advantageous in patients where the breath hold is a big problem, like for example those who are admitted, and quite a few of the indoor patients, you have a lot of difficulty asking them to breath hold. Some of the elderly patients, especially in pediatric age group, this problem is a huge problem. It's very difficult to ask them to breath hold. So in that scenario, what you can do is, even if the patient is breathing, like for example in this case, you record a loop for a bit. So you record a small loop, you capture a few frames, and then you can just go back. You can just go back to the frame where you think the images come up well, and you can take your reading over here. So this is an advantage which you don't have in a point shear wave, and this is definitely of tremendous value. So there are a couple of things that we need to keep in mind before we go on to interpreting our image. The first thing, we have already seen that we do not take the measurements in this red area or where the confidence is low. We have to only take it in this green area. So that is the confidence measurement. The second thing that we need to ensure is that we look at this IQR upon median. So at the end of your study, when you go to your report page, there's this IQR upon median value which pops up in the report, and if you're looking in terms of kilopascals, it has to be less than 30%, and if you are looking at in meters per second, it has to be less than 15%. So this gives you an assurance, or a kind of a quality assurance of how you have done your study. So in this case, yes, we have done a fairly decent job. We are less than 24% in terms of kilopascals and 11% in meters per second. It almost kind of actually correlates, so you can look at just one, you don't need to look at both. And the closer you are to zero, it's much better. So you want this to hit, you want this to be as close to zero as possible. That means you have done a fantastic job. The other thing you look at is, when we are reading these values, in case of liver elastography, we are going to look at this median value. So the median value is what is going to be used for your interpretation of your report. So this is in the median value popping up. You have a whole plethora of findings. You have an average, standard, etc. But what you look at is at this median value. So now that we have taken our values, how do we interpret it? So all this while, what we used to do is try to correlate our findings and put it in a Metaweight score. We try to get the histopathological variation. We've been trying to say whether this is a F0, F1, F2, F3, whatever. The problem with this is there's a lot of overlap with values. So the new SRU update which has come up recently talks about the rule of 4, and this is valid for your viral etiology, so hepatitis B, C, and your non-alcoholic fatty liver disease. So what it does is we classify these findings in this particular fashion. So if your value is less than 5 kilopascals or 1.3 meters per second, there's a high probability that this is normal. If the value is less than 9 or 1.7 meters per second, and there are no other known clinical signs, it potentially rules out a compensated advanced chronic liver disease. But if there are any clinical signs, we need further tests for confirmation. Values between 1.7 to 2.1 meters per second or 9 to 13 kilopascals are highly suggestive of a compensated advanced chronic liver disease, but we need further tests for confirmation. If the values are more than 13 kilopascals or 2.1 meters per second, this rules in a compensated advanced chronic liver disease. And if these values are more than 17 kilopascals or 2.4 meters per second, these are indicative of a clinically significant portal hypertension. So this is the rule that we need to keep in mind going ahead. Now, another important thing that we need to remember is that when we have patients for follow-up, and if they are on treatment, so they are, like, for most of the hepatitis B and C patients are now on active treatments. So when they come to you for a follow-up, do not grade them again. We have the previous values as the baseline values, and now when the patient comes in, you assess whether they have improved or whether they have gone down. So this is what is called as a delta change. So suppose the patient comes to you today, you keep that value as your baseline value, and the patient comes to you after 6 months, you look at that 6-month value in reference to your today's value. So, and you see whether this is increased or decreased, and any change more than 10% becomes clinically significant. So this is called as delta change. Now this can be applied for almost anything, even in children, because there are no known cutoffs which are there or published for children. So even in these cases, when the first time the baby comes to you or the kid comes to you, you have those values as a baseline value, and you progressively go on monitoring these patients and say whether they have improved or whether they have worsened. The other very frequently asked question is, how do we interpret fatty livers on elastography? What I want to tell you is, whatever I have shown you up till now is only to assess fibrosis. We are not assessing fatty livers or the quantification of fatty livers on that. Well, but there is a new technology coming up. Hopefully in a couple of years this should be very well published, and we'll be able to even grade our fatty livers. But these are some of the new systems. For example, over here we have the supersonic Mach 30 machine, where we are able to get some quantification of a fatty liver. So beginning with what we have is what is called as the hepatorenal index. So for that, what we do is we take the image of the liver and the kidney in the same section. We go to our auto, where we are optimizing the B mode, Shwastamba, and we take an image, Aramat Shwaski. Now once we are done with that, what we do is we go to this B mode ratio. We place our box first within the liver, and then we have to place a box within the renal cortex at exactly the same depth. This is very important, and we get this ratio over here, which is 1.47, and the interpretation of this is something to this effect, that when we have a ratio which is, say, up to around 1.2, there is a minimal risk of steatosis. If the ratio is anywhere between 1.2 to 2, there is an intermediate risk of steatosis, but if the ratio is more than 2, there is a very high risk of steatosis. Now one thing I would just like to say is that this is still not very widely used, not very widely published, so we will have to wait for some time to arrive at better conclusions, but nonetheless we have started using this technology, and hopefully we should be getting there soon. The other thing which can be done for the fatty liver is the attenuation coefficient. So what we do over here is we turn on this attenuation mode. We get this big box. The box is not changeable in size, and we have to take the measurements as it is. So again, we ask the patient to stop the breath hold. Shwastamba. Suddenly. It's a prudent idea to take at least 3 readings, and then we can take an average of these 3 readings. So we look at 2 factors over here. You have the attenuation and you have the sound speed. So the attenuation should be less than 0.66 when we are looking at a healthy liver, and the speed of the sound in the liver should be more than 1537 meters per second. So this is indicative of a healthy liver, and of course vice versa. The other important thing that can be measured on this Shwastamba, on this machine, is the viscosity. So where this helps us is in assessing inflammation. Shwas Sodunde. And what we are able to differentiate is acute flare-up of hepatitis. So this is a very common confusion which pops up when we are looking at very high values, and our B mode and the elastography findings are not correlating. This is very frequently seen with acute hepatitis, and we are able to identify, or rather separate, those cases on that. So if we see a value which is more than 1.8, we know that this is suggestive of an inflammation.